بسم الله الرحمن الرحيم. الأول لازم أشكر طبعا دكتور حسين والأورجنايزنج كوميتي على الدعوة. ويعني احنا دايما بقول إن احنا محظوظين، يعني طبعا إن احنا عندنا ريفرنس وقامة زي الدكتور حسين. بنرجع له دايما في الأوقات الصعبة بناخد رأيه في المواقف الصعبة. النهاردة هحاول أبقى أوصل مسج زي ما طلب مني، مسج in a video. A real life situation, a 55 years old female presenting by dull aching diffuse abdominal pain for around 2 years. Her clinical examination was insignificant apart from marked hepatomegaly with no signs of liver cell failure. Her laboratory investigation only showed increase in the ALT up to 2 folds only. Her virology screen was negative, as well as her tumor markers were all negative. She did abdominal ultrasonography that showed hepatomegaly of diffuse pathology with multiple hepatic focal lesion. So her referring physician ordered her a PET-CT, which revealed metabolically active pancreatic body tail soft tissue lesion around 2.5 centimeters in diameter, mostly neoplastic, with innumerable metabolically active bilobar hepatic focal lesions with increase of the FDG uptake up to 43 SUV, very high, as well as peripancreatic lymph nodes. So we decided to do EUS in objective of biopsying of the pancreatic, as well as, if possible, the hepatic focal lesion. So So we did the EUS, and we tried to show first multiple hepatic focal lesion. We'll try to identify better innumerable very large hepatic focal lesion, as you can see. And just to note that the patient didn't show any alteration of her general condition, no jaundice, no weight loss, no stigmata of liver cell failure, only mild increase of the liver enzymes in spite of the dissemination of the hepatic focal lesion in the liver. As you can see, these lesions are hyperechoic, surrounded by some sort of capsule, and they're not very highly vascular. So this is not the typical pattern of what we can see from liver mets or even of a primary of the liver, HCC or something. Also, we try to trace the pancreas. Here we can see the lesion at the level of the tail of the pancreas, hypoechoic lesion around 2 centimeters at the level of the tail of the pancreas. So we decided to perform biopsy from both the liver and from the pancreas. We biopsied first the hepatic focal lesion. It was easily accessible. So we started by the hepatic focal lesion. Then we performed from the pancreatic tail lesion. The head was didn't show any focal lesion. There was no dilatation of the common bile duct, and even in spite of the presence of such large lesion in the liver, there was no intrahepatic biliary radical dilatation, and laboratory there was no derangement of the liver functions. So just to save time, as you can see here, we are screening the body to reach the lesion at the tail of the pancreas. And we performed the biopsy from the tail. So her pathology was adenocarcinoma with possible neuroendocrine feature, high grade associated with hepatic tumor metastasis for immunophenotype. الحقيقة في الموقف ده بتبتدي الصعوبة، يعني احنا دايما بتبقى الواحد منتظر الباثولوجي عشان يحل الكيس، لكن في المواقف دي بتبتدي الصعوبة في الحالة.
يعني انه الليفر دي هيباتيك تيومر ميتاستاسيز، دي ديبوزيتس ليفر ماتس من البنكرياتيك تيل ماس. بالظبط يا فندم، هو ده اللي طلع. لكن هي دي مشكله النيورو اندوكراين نيوبلازم، الاميون فينوتايبنج فيري دايفيرس، والديفينيشن بتاعه فيري تشالنجينج. عشان كده هحاول ادي ريزوميه بسرعه how to manage when you have a pathology reporting neuroendocrinal tumor. طيب pancreatic neuroendocrinal neoplasms, what we call PANN or islet cell tumors, are types of neoplasms that originate from neuroendocrinal cells. Pancreatic neuroendocrinal tumors are less common type of pancreatic cancer, less than 2%. They arise almost anywhere in the body, بس ليهم preference في gastroenteropancreatic system and the lung. Some inherited syndromes increase the risk of pancreatic NATs, like the MEN type 1, the von Hippel-Lindau, von Recklinghausen, and tuberous sclerosis. Even some centers, they do screening with EUS for MEN type 1 to screen for PANN in the pancreas. The immunohistochemical profile of PAN-NATs is essential to establish the diagnosis. The diagnosis includes the expression of cytokeratin, synaptophysin, chromogranin A, and Ki67. The most common marker are chromogranins, they are the more specific, and the synaptophysin are the most sensitive. Other markers like the CD56 insulinoma-associated protein are used even. But in poorly differentiated neuroendocrine neoplasm, you may need more than one marker to confirm the neuroendocrine nature of the lesion. The WHO modifies its grading of neuroendocrine tumor. Consequently, there are different grades, grade 1, grade 2, grade 3, according to the differentiation, the mitotic figures, as well as the Ki67 index. We have the low grade, intermediate, and high grade, and at the end, the poorly differentiated or the carcinoma. We have to identify also the tumor function, if it's functioning neuroendocrine tumor or non-functioning. Functioning are about half of pancreatic NATs are make hormones that are released in the blood and cause symptoms. The most common is insulinoma. Less common are gastrinoma, chromogranin, and serotonin. Non-functioning, they don't express tumor hormones, but they may cause symptoms if they grow, and they cause, because of their size, they may cause symptoms. And finally, the carcinoid tumor is not very common in the pancreas. It's more common in the gut, in the GI tract. According to the hormone, we have to identify the type: carcinoid, gastrinoma, insulinoma, glucagonoma, vipoma, or somatocytinoma. And according to the type, we have the needed laboratory test to identify, and the risk of metastasis according to the type of functioning tumor. Which test to use? CT and MRI are used essentially as a screening, but still EUS is very sensitive, is very high, especially for identification of small nets less than 2 centimeters, especially gastrinoma in the Passaro triangle and insulinoma. And of course, biopsy is crucial and essential. Recently, PET MRI with gallium DOTA-TOC, it's not DOTATATE. Recently, the FDA approved the DOTA-TOC, which is radioactive material that is superior than DOTATATE to guiding management and to screen for bone and hepatic lesion. So the ideal is to do PET with gallium DOTA-TOC. The US for PANN, typically pancreatic nets appear as hypoechoic, well-demarcated, round, homogeneous lesion. While the majority are solid lesions, some may be appear cystic. Potential pitfalls, please take care that it may be isoechoic, so you may miss it, may be very small in size, may be multiple. It's not rare to have a lesion in the head and another lesion in the tail, may be pedunculated at the level of the tail, so please screen carefully the tail of the pancreas. And you have to screen for adjacent lymph nodes. The US is very sensitive. The average size of insulinoma is usually less than 1 centimeter. Gastrinoma are located, as I said, 80% in the Passaro triangle. And as for the treatment, surgery if the lesion is confined to the tail, if in the head, Whipple may be offered. radiotherapy, but recently target therapy is used also according to the biologic features of the tumor. Radiofrequency ablation for patients who are not surgically fit and for localized tumors. Of course, for hepatic or liver deposits, you can use hepatic artery occlusion, chemoembolization, radioembolization, and liver transplantation may be offered, and for end stage for chemotherapy. So in conclusion, EOS is especially useful for gastric, duodenal, pancreatic, and rectal NETs. It provides additional information on the depth of invasion and can assess local lymph node involvement. Further advantages of EOS include the ability to perform a fine needle to obtain tissue for cytological and molecular analysis. And finally, radiofrequency ablation may be a choice for poor surgical candidate. Thank you.
متشكر يا دكتور محمد، ده حاله جميله جدا، وانت اديتنا مسج جميل جدا واضحه ان النيورو اندوكراين تيومر ده ممكن يبقى 1 سنتيمتر وعندك ميتاستاسيس 4 to 5 سنتيمتر. ملحوظه غريبه ومالتيبل واكستنسيف، يعني اديتنا مثال كلاسيك لانك ازاي ان تيومر صغير سنتي او سنتي ونص يديك مالتيبل ليفر ميتاستاسيس ويديك اجريسيف هوريبل ليمف نودز. الملحوظه الثانيه ان في المانجمنت لو هو سمول نت اقل من سنتي واسيمتوماتيك، يعني smaller than 1 سنتيمتر and asymptomatic يعني مش functioning، ممكن ان احنا نعمل له فولو اب. فوق 2 سنتي لازم يتشال حتى لو كان asymptomatic. بين سنتي و2 سنتي ممكن نجرب الراديو فريكونسي ابليشن. يعني هل حضرتك موافقني على هذا الموضوع؟ لان بنقابلنا كتير قوي اكسيدنتالي نلاقي تيومر صغير 7 8 مللي والعين ما بيشكيش من حاجه خالص. اذا ما كانش بينفول ما كانش عامل بين واكسيدنتالي ديسكفر سنتي تحت سنتي نسي.
ما هو بالظبط حضرتك ملاحظه حضرتك دقيقه انه النون فانكشننج بيبقى الامباكت بتاعها بناء على السايز. فهي لو هي صغيره usually it will be asymptomatic and maybe only accidentally discovered, so just follow up. النقطه الثانيه اللي فعلا حضرتك هايلايتد ودي مسج مهمه قوي، انه لما الاقي ليفر ديبوزيتس بالحجم ده وانه liver function normal, tumor marker negative, general condition not affected, I have to think out of the box. It's not HCC or just liver mets from traditional adenocarcinoma.
تمام. دكتور حسين، what's about somatostatin antagonist في الinoperable
somatostatin تريتمنت يعني؟ كتريتمنت ولا كدايجنوزس؟
كتريتمنت.
لا كتريتمنت. انا مش اونكولوجيست، لكن انا قابلني 3 حالات خدوا سوماتوستاتين، بس دول اللي بيبقوا فانكشننج، بيحب يديهم في الفانكشننج ليجن اللي ان اوبرابل. يعني العيان بتاع الدكتور محمد ده عندك في الليفر ميتاستاسيس هوريبل وليمف نودز هوريبل، ملوش حل، تدي كيموثيرابي ومعاه بس لو فانكشننج تدي سوماتوستاتين. ده اللي انا بلاحظه.
دي فانكشن.
لا دي مش فانكشن.
دي مش فانكشننج.
لا ما كانتش.
لا ما فيش سيمبتومز، ما عندهاش بين، ما عندهاش دايريا، ما عندهاش فلاشنج، ما فيش.
لا عملنا له مثلا
ما فيش سيمبتومز. احنا بنعمل فانكشنز بناء على
ما فيش سيمبتومز.
ما فيش سيمبتومز بيبقى فيها مالجنت.
احنا بنعتمد في الفانكشن سكريننج على السيمبتومز، يعني بعمل سيروتونين، بدور على الفيبوما، بدور على الجاسترين سكريشن لو في سيمبتومز، ريكارنت ألسرز، لارج جاستريك ألسرز، دايريا، فلاشنج. لو انسولينوما هتبقى في هاي انسولين ليفل ولو سي بيبتايد ولو جلوكوز.
بتبقى بناين، انما جاسترينوما ممكن نلاقي فيها.
بس الجاسترينوما لو هي فانكشن هيبقى في هاي اتش سي ال سكريشن.
هو كان في برضو بالنسبه للميتس يا دكتور محمد، الحاله طبعا رائعه الجمال ما شاء الله عليك. الميتس كانت حواليها هولوساين بالظبط، ايفن ان هي كانت هايبر اوكويك، فالهولوساين دي لوحدها تقول لك انديكيشن لا دي في الغالب مالجنانت.
بالظبط، وهو ده الاتيبيكال برزنتيشن. هي المسج انه مش دايما نستسهل انه نقول انه ده ادينوكارسينوما ويز ليفر ماكس، لا لازم افكر انه لو في حاجه اتيبيكال ان انا افكر انه it is atypical, it's uncommon pathology. لان احنا التراديشنال انه ادينوكارسينوما ويز ليفر ماكس.